Moving on to the vasculature, here you can see the abdominal aorta and its important branches. This is important to know as infarcts in the different branches will affect different structures. The celiac trunk, which you can see here, we'll talk about in more detail in a moment. The celiac trunk is the first abdominal branch and it leaves around T12. Below that anteriorly is the superior mesenteric artery, or the SMA, and this is at the top of L1. The inferior mesenteric artery, or the IMA, is at L3. Between the mesenteric arteries are the paired renal arteries, which usually occur around the lower edge of L1, as well as the gonadal arteries at L2. The bifurcation of the aorta occurs at L4, which you can see here. So from T12 down to L4, we have the celiac trunk, the superior mesenteric arteries, the renal arteries, the testicular or ovarian arteries, the IMA, and lastly the bifurcation. At the bifurcation, the aorta divides into the left and right common iliac arteries, and then the common iliacs bifurcate shortly after into the internal and external iliacs. Another way to categorize these arteries and remember what they supply is by looking at their branching off points. Arteries that branch off anteriorly go to the gut, which includes the celiac trunk, the SMA, and the IMA. Meanwhile, arteries to non-GI structures branch off the aorta laterally. A commonly tested concept is SMA syndrome. This is where the SMA traps between itself and the aorta a part of the duodenum, and this causes an intestinal obstruction. Let's go over this in a table form to cement our learning. The table here provides some information on the blood supply and the innervation of various gut regions. It's easiest to remember if you think about it in terms of development. Let's quickly review and expand on what we went over in embryology. The foregut, which consists of the pharynx to the proximal duodenum and the nearby structures including liver, gallbladder, pancreas, and spleen, receives blood from the celiac trunk. This region is innervated by the vagus nerve. A quick review, where does the celiac branch? That's right, it branches at T12. Next is the midgut, which consists of the distal duodenum to the proximal 2/3 of the transverse colon. This means the entire small intestine and ascending colon are included. And all of these are supplied by the SMA and innervated by the vagus. The last section is the hindgut. What does the hindgut give rise to? It gives rise to the distal 1/3 of the transverse colon to the upper portion of the rectum. And it receives blood from the IMA and is innervated by the pelvic nerves. Of special note is that the splenic flexure, which is the region located 2/3 of the way across the transverse colon. The splenic flexure is a watershed region. What does this mean? Well, the splenic flexure is on the border of the SMA and IMA blood supply, and watershed regions like this actually receive less, not more blood. The reason this is clinically relevant is that in episodes of global hypoperfusion, when there is a disruption in blood flow by hypotension, the watershed areas are the first to suffer from ischemia. This is paralleled in the brain as well. To help you remember the order of the arteries, think of the acronym CSI. Okay, let's do a quick flash quiz. Which artery supplies the hindgut? That's right, it's the inferior mesenteric artery. Let's next talk more about the celiac trunk. I think you'll find it helpful to draw this out on your own a number of times. But right now, let's go over the path of the blood flow. Do you remember where the celiac trunk comes off of the aorta? Again, it's T12. Can you tell that it's important? The celiac trunk branches into 3 arteries: the left gastric artery, the splenic artery, and the common hepatic artery. The right gastric branches at a later point, which you can see here. The left gastric and the splenic arteries join up with other vessels later on, but essentially they are going exactly where their name suggests. The left gastric is going to the left side of the lesser curvature of the stomach, and the splenic is going to the spleen. The common hepatic artery, on the other hand, continues to branch. The first vessel to leave the common hepatic is the gastroduodenal artery. And then, as the common hepatic continues to become the proper hepatic artery, it gives rise to the right gastric artery. The proper hepatic, as its name suggests, which you can see here, continues to the liver, and it bifurcates into the left and right hepatic arteries. The right hepatic artery gives off the cystic artery before supplying the right liver. Let's look at the gastroduodenal artery, which you can see here. The gastroduodenal artery supplies the stomach and the duodenum, as the name suggests, and it does this by branching into the superior pancreatico-duodenal artery and then the right gastroepiploic artery. The gastroepiploic arteries supply the greater curvature of the stomach, which you can see here. Although it looks like the right gastroepiploic continues to the left gastroepiploic, officially the left is a branch of the splenic artery, as are the short gastric arteries. This clearly is fairly complicated anatomy, but it is important to understand, especially since gastric ulcers can erode through the stomach and can lead to hemorrhage by involving the nearby arterial systems. This commonly will be tested on the boards. A common location for these type of lesions occurs at the pyloric region of the stomach, where ulcers can involve the gastroduodenal arteries and cause massive hemorrhage. A good understanding of the anatomy can help surgeons accurately and quickly assess which arterial system is the cause of the bleed and where to ligate potentially bleeding vessels. The portosystemic anastomoses are similar, but we generally think about them in the context of hepatic pathology, typically cirrhosis and portal hypertension, and this connection is commonly tested. As we go through them, you can relate it to the mnemonic, varices of the gut, butt, and caput, or caput medusae. The first anastomoses to mention is at the esophagus, where the left gastric can send blood to the esophageal veins. When the blood cannot pass through the liver, it sometimes is forced to the alternate route of the esophagus, and clinically patients may develop esophageal varices. On the boards, how would this present? Well, esophageal varices present as upper GI bleeding. The next anastomosis is at the umbilicus, where the paraumbilical veins connect with the superficial and the inferior epigastrics. If blood is backed up here, patients develop caput medusae, which are dilated abdominal vessels seen in cirrhosis. Thirdly, there is an anastomosis at the rectum between the superior rectal and the middle and inferior rectal veins, which you can see here. This manifests as internal hemorrhoids. One therapeutic measure to deal with portal hypertension is the TIPS procedure. TIPS stands for Transjugular Intrahepatic Portosystemic Shunt. This procedure places a shunt between the portal and hepatic vein. The shunt between the portal and hepatic vein is placed percutaneously and thus bypasses the blockage in the liver to allow blood to return to the systemic circulation from the abdomen. This relieves the pressure on the other anastomoses. The pectinate line is a structure in the rectum that divides the anal canal into the upper 2/3 and lower 1/3. Embryologically, this is the point where the hindgut meets the ectoderm. On the exam, it's common for the differences of the pathologies above the pectinate line and below the pectinate line to be tested. Thus, above the pectinate line, patients may develop pathology that's relevant to embryonic hindgut derivatives. As a review, what portion of the GI tract is derived from the hindgut? The hindgut contributes from the distal 1/3 of the transverse colon to the upper rectum. These pathologies include internal hemorrhoids or adenocarcinoma, sometimes called rectal colon cancer. The blood supply to this region is from the superior rectal artery, which is a branch of the IMA, and venous drainage is to the superior rectal vein, which feeds to the IMV. Below the pectinate line, in what is essentially normal skin, patients can develop external hemorrhoids or squamous cell carcinoma. The blood supply to this region is from the inferior rectal artery, which is a branch of the internal pudendal, and then the blood exits via the inferior rectal vein, which connects with the internal pudendal and then the internal iliac before reaching the IVC. Because the superior 2/3 of the vault is part of the GI tract and the inferior 1/3 is the ectoderm, internal hemorrhoids in the superior 2/3 are not painful and drain to the deep lymph nodes. Do you think external hemorrhoids are painful? That's right, they are. External hemorrhoids in the inferior 1/3 are quite painful since the inferior 1/3 is innervated just as copiously as the rest of the skin, and they drain to the superficial inguinal lymphatic nodes. Additionally, internal hemorrhoids may be a sign of portal hypertension, as we just mentioned in the Portosystemic Anastomoses section. Commonly tested on the exam is where the drainage from these structures occur. Again, let's review it. Above the pectinate line, lymphatic drainage is to the deep abdominal lymph nodes. Below the pectinate line, lymphatic drainage is to the superficial inguinal nodes. These are really important to remember. Now for a flash quiz to solidify what we just went over. What type of hemorrhoids occur above the pectinate line, and what type occur below the pectinate line? Well, above the pectinate line, it's the internal hemorrhoids. Below the pectinate line, it's the external hemorrhoids.